With that, I'd like to tell you about our host tonight. Dr. Bojana is an award-winning physician. She's double board certified in internal and integrative medicine. After completing her internal medicine residency, she did a fellowship in integrative medicine, trained in functional medicine and nutrition and mindfulness. Her approach, of course, is rooted in evidence-based medicine, and she personalizes that to each individual that she works with. She partners with her patients to discover and address the root causes of their conditions and develops individualized plans to support each individual to achieve his or her health goals. As a part of her mission to deliver accessible evidence-based health and wellness information, she created her website, drbojana.com. That's DRBOJANA.com, where you can check out her videos, articles, and recipes, and a whole wealth of expertise to share with your patients. And with that, Dr. Bojana, I'll turn it over to you. Thanks again for being here with us tonight.
Thank you so much for having me. It's such a pleasure to partner with you guys on this webinar, and I'm a huge fan of Epicured's work and mission, and have to say that having had the pleasure of trying out some of your meals, I do think that they're very delicious, high quality, and I think such a wonderful solution to patients when they're struggling with implementing the low FODMAPs diet, which I know can be so challenging for a lot of our patients. And so thank you for the work that you do. So I'm going to be talking today about the integrative medicine approach to irritable bowel syndrome, and the context of that is going to be mastering the gut-brain connection. Let's see, it looks like I'm having trouble advancing. Oh, okay, here we go. So this is just the disclaimer that I'm not giving specific medical advice. So I'm just going to share with you what to expect from this talk so that we can kind of go into this with a common intention and really look for those clinical pearls that are going to help you in your own day-to-day interactions with patients and help you guide patients. So number one, my goal is to develop an understanding, help you develop an understanding of the gut-brain connection as we know it and as we understand it today. Number two, understand the etiology of IBS and current treatment recommendations. I'm also going to help you understand why the gut-brain signaling is important in the context of IBS. And I'm also going to help you feel a little bit more comfortable perhaps in discussing this importance of the gut-brain connection with your patients. Because once, and we all know this in practice, once our patients have a deeper understanding of what is going on physiologically and how they can help themselves, this is going to greatly transform the course of their condition. And especially in the context of IBS and many of the GI symptoms, a lot of the work is on the patient when it comes to dietary transformation, as well as when it comes to some other integrative modalities that I'm going to be speaking about. So it's really, really important to make this information accessible to the patient and to really distinguish between evidence-based versus fads versus some new and exciting research. And number five, I'm going to help you improve the efficacy of your intervention by understanding and using evidence-based modalities that will help your patients alleviate IBS symptoms. But first, let me tell you a little bit about myself and the context of my own training and experience in this presentation. So after doing my undergrad and master's degree, I completed my MD at the University of British Columbia in beautiful Vancouver, where I lived at that time. And then I went on to complete my internal medicine residency training at the Cedars-Sinai Medical Center and West LA VA in Los Angeles, California. I subsequently went on to practice primary care with the Cedars-Sinai Medical Group in LA, and then actually just moved to New York about 2.5 years ago and started my own practice here a little less than a year ago, where I do internal medicine as well as integrative and functional medicine and provide support to people with a variety of chronic conditions as well as preventative and primary care. So let me share with you a little bit about the road that led me to integrative and functional medicine, because it certainly wasn't something that I ever anticipated in my training, and because what I'm going to be talking to you about is going to draw from some of the integrative and functional medicine principles, I felt that this was important to start with. So as you can see this picture in the middle, right, probably most of us whether, we're thinking about our professional or our personal goals, we often think that our roadmap is going to be this linear, beautiful roadmap. Everything is going to be clearly outlined from point A to point B to point C and so on. And then at the end of it, we're going to see this beautiful sunshine as illustrated in the picture on the left. However, as you can imagine, my road definitely was a very windy one, where at times I could not see the sunshine, and there were a lot of shadows and a lot of uncertainties really, and unexpected situations that really led me to where I am today. So the first critical point that I'm going to share is it really started during my residency training. And so I was pregnant twice during my residency training. I was talking to my OBGYN and talking about, well, when is the right time? Should I wait until later? Should I have my babies now? And he said, listen, it's like the Nike slogan, just do it. And so I just did it. I had my children, but on the way, there were definitely a number of crucial and transformative lessons learned. So as you can imagine, in residency training, I was doing these 30+ hour shifts, very long hours. And when you have a baby growing inside of you, that can sometimes be challenging because you may be presented with exhaustion and burnout and physical and just mental and emotional fatigue. And while I was able to keep myself hydrated with a bottle of water in the pocket of my white coat and keep some almond snacks and apple and a banana in the other pocket, it didn't really prevent me from really facing the burnout and exhaustion, as well as some serious concerns about what I'm doing to this fetus, given these long hours and caring for very sick patients. And I was very torn because I loved what I did. I loved medicine. I loved that I finally got to take care of patients. But at the same time, it took a toll on my body. And so and then on top of this, my babies were measuring very large, and my OBGYN brought up the possibility of a C-section. And so one night, in the middle of the night, I woke up, and this was the first critical point. I couldn't go back to sleep. I was really emotional and really kind of distressed. Because of what these hours and what this lifestyle was doing to my babies. And of course, being the science nerd that I am, I immediately went on to PubMed and started to look for data on shift work, long hours, burnout, exhaustion, on pregnancy complications and premature labor. And of course, there was plenty of evidence. So this did not make things any better. However, it drove me to this point where I had to make a decision. I was either going to be a victim of the circumstances that had presented themselves and that I was a part of creating, or I was going to take ownership of my health, of my condition, and seek modalities and seek ways in which I can help myself physically and emotionally. And so I did just that. I started working with a prenatal yoga instructor. I started working with an acupuncturist and chiropractor to help my body prepare for the labor of these large babies. And actually one of them was over 10 pounds. So definitely needed that support. And I also started working with a birth doula. And what I found is that through yoga, acupuncture, chiropractic work, working with a birth doula, working on hypnotherapy, it really helped both my physical and my mental and emotional states shift. And it took some time, but I was very persistent with these practices to the point where the shift was so huge that I no longer felt this huge burden and this huge exhaustion and burnout the further along I got into my pregnancy. And so interestingly, I took note of that, but it didn't really change my trajectory. Of course, I completed my internal medicine residency and so on. And thankfully, I did give birth to these beautiful babies. So then I went on to practice as a primary care physician. And as you can imagine, I was starting to work with many patients that have chronic conditions. So I was working with a lot of people that have chronic fatigue that may not have been diagnosed, people with depression, anxiety, thyroid problems, many patients with gut issues, and in particular, a lot of patients with IBS And, you know, it was that typical presentation where they're having either change in bowel habits and tending more towards diarrhea versus tending more toward constipation, bloating, gas, abdominal discomfort. They may have had a full GI workup, nothing found on the GI workup, and really presented with very limited options and a whole lot of frustration. And so I got really curious about these patients because I wanted to figure out how can I help them beyond medications. And we're going to go through what the current therapeutic modalities are, and I'm going to add on some of the integrative modalities for which there is evidence as well. But I really wanted to go beyond and understand what is the root cause of this? What is going on at the physiological level? How can I support these patients? How can I empower them? And really, it then really clicked for me because I wanted to empower my patients the way that I was empowered by my integrative medicine practitioners when I was going through my own health journey during residency while pregnant. And so this really led me to pursue my integrative medicine fellowship and then functional medicine training, as well as mindfulness-based stress reduction training, all of which I apply in my current practice when I see patients presenting with chronic conditions or wanting preventative care. So this is going to kind of help set the stage for what we're going to talk about today. I'm going to share a little bit more about what exactly integrative and functional medicine are, and then we're going to dive right into what IBS is, what causes IBS, what is the connection between the microbiome, the gut, and the brain, what is intestinal permeability? Does this even exist? And how does this play a role in IBS, in autoimmune disease, and other presentations? I'm then going to talk about the current treatment of IBS. And then I'm going to talk about some of the integrative medicine modalities, including herbs and supplements, and share some of the evidence for this as well. I'm then going to talk about SIBO, small intestinal bacterial overgrowth, in relation to IBS and what to do about it. And then at the very end, I'm going to share a case study with you. So integrative medicine really has as its foundation conventional medicine, academic medicine, evidence-based medicine. And it really embodies the principles that we all should be practicing no matter what the kind of label is of our practice, whether it's functional, whether it's conventional or not. So the patient is at the center of this approach, and it's really the patient and practitioner that partner in the healing process. We want to consider all dimensions of well-being. So we want to think about nutrition, of course, movement, sleep, stress, but we also want to think about the patient's community, their support system, their spirituality. What is their sense of purpose? What brings them joy or what brings them down? We also, in the context of integrative medicine, take into consideration evidence-based modalities, both from conventional but also complementary approaches. And we do not reject conventional medicine, nor do we accept alternative therapies uncritically. So this is really something important where there are a lot of misconceptions about integrative medicine. And then the goal, of course, is to develop a customized plan based on the patient and condition factors to effectively deal with a given condition. And of course, as always, we want to focus on prevention. So rather than dealing with a chronic disease, let's find a way to prevent it. So what is functional medicine? It distinguishes itself a little bit in that it really kind of focuses on addressing the root causes of disease, which sometimes we may know what they are and other times it may not be so easily identifiable. And it also focuses on assessing the patient's biochemical and lifestyle factors and uses this information to create a plan that's specifically customized to a patient. And interestingly, a recent study came out from Cleveland Clinic showing that health-related quality of life is actually significantly improved when patients are treated in a functional medicine setting. Definitely, we need more information on this as well as how to really scale this approach in today's world. So what about IBS? Let's talk about the Rome 4 criteria. And we all, I'm assuming that you guys already know this, so I'm just going to go through this very quickly. So with IBS, the patient should have abdominal pain on average at least one day per week that lasts for at least 3 months and is associated with 2 or more of the following symptoms. So it may be related to bowel movements, associated with a change in the frequency of stool, or associated with a change in the form of stool. And there are 4 different categories, right? We have the constipation predominant, diarrhea, we have the mixed, and then unclassified. So IBS is associated with a number of conditions and symptoms. right? We know that there's a component of mental health, stress, trauma, and we know that IBS has as its comorbidities oftentimes depression and anxiety. It has also been associated with the imbalance of gut bacteria. So either small intestinal gut bacteria, which we know is small intestinal bacterial overgrowth, or dysbiosis in the colon. It may also come as sequelae of infections in the digestive system, right? So oftentimes we may have a patient that was infected with a parasite and subsequently developed IBS, or a patient with a bacterial infection that developed IBS. It can also, however, develop as a result of or in relation to increased intestinal permeability. And we're going to talk a little bit more about this later on. And increased intestinal permeability can occur in association with standard American diet, but also in association with antibiotics, right, which wipe out our normal gut flora, which are so important for many different processes. IBS has also been implicated, or food sensitivity rather, has also been implicated as a possible cause of IBS. However, this is still somewhat debated. And then inflammation, of course, of the digestive system can occur in IBS. And inflammation can occur in the context of the above factors that I've mentioned. So imbalance of the gut bacteria, infections, increased intestinal permeability, right? They all increase the risk of inflammation. I'm going to discuss how. And then, of course, there's genetic predisposition. So what about this dysfunction of the gut-brain connection, right? So this is really at the root of IBS, and we're going to talk about how and why. But first, I'm going to talk about just going to mention these three components of IBS, right? So we know that there's this visceral hypersensitivity, and this is really related to the pain of abdominal viscera that patients with IBS may feel more intensely than what we would normally expect. And then there are psychological factors, as I mentioned previously, right? Difficulty regulating the stress response. So oftentimes our IBS patients, they go on vacation, right? They're doing so much better, and they may not have changed a thing with their diet. They may not have changed anything else, but they go on vacation, they're less stressed, and they're just doing much better. And so we know that there's a huge component of how we're actually regulating stress. And in relation to that, autonomic nervous system. So this is really, really interesting. It's been found, and we're going to talk about the autonomic nervous system and the vagus nerve, which is part of the parasympathetic nervous system. But it's been shown that the vagal tone has been decreased in patients with IBS as well as Crohn's disease, which is a type of inflammatory bowel disease. So we know that there's this dysfunction or dysregulation of the autonomic nervous system, which is so important in sending messages from the gut to the brain and vice versa. And we know that both digestive system and the brain play a role in GI disorders. So as I mentioned earlier, IBS and psychiatric conditions, and it really goes both ways. It's really a two-way street. And intuitively, we know this as well, right? We talk so much about the stress response, right? So if we're facing a tiger that's about to run after us and eat us, it doesn't make any sense to divert blood flow to the gut and to start digesting, right? We need our muscles, we need to run, we need that adrenaline, we need to increase the heart rate, and we're running away from that tiger. If we, however, are with our loved one or with our beautiful little kitten, our pet, we're relaxing. We are ready to rest and digest. It makes sense for us to be able to need to feel safe in order to digest. So we know that evolutionarily, there's a reason that we developed in this way, but that also means that we need to be mindful of our stress and how we react to our stress and what we do preventatively to manage our stress in order to optimize our gut function. So let's talk a little bit more about this bidirectional gut-brain connection. So as I mentioned, this connection refers to the central nervous system and the enteric nervous system, right? And the enteric nervous system is really the brain of the gut. It's this collection of neurons in the GI tract that is this brain of the gut. And what's really fascinating to me is that it can function independently of the central nervous system. It controls gut motility. It controls exocrine and endocrine secretions, as well as microcirculation of the GI tract. And it's also actually involved in regulating immune and inflammatory processes as well. And this enteric nervous system is really described as the second brain. And it communicates with the CNS, or with the brain, through the parasympathetic nervous system, i.e. via the vagus nerve. And the vagus nerve is depicted here in this picture on the right. And it also, the enteric nervous system also interacts with our brain via the sympathetic nervous system, and this is via the prevertebral ganglia. So what's really interesting is that, as I mentioned, vagus nerve plays a huge role in the communication between the gut and the brain. What's really interesting is that 90% of the vagus nerve fibers are afferent fibers, meaning that they sense information in the gut and they send this information back to the brain. And only 10% of the vagus nerve fibers are efferent, meaning that they take the information or direction from the brain to act accordingly in the gut. And vagus nerve plays a very important role in appetite, gut motility, and inflammation through these back and forth, by enabling really this back and forth channel. And as I mentioned earlier, the vagus nerve function is reduced in individuals with IBS and Crohn's disease. And there are actually some natural ways in which we can help stimulate the vagus nerve as well, but I'll mention that if we have time later on. So another way to really kind of dive a little bit deeper into this bidirectional gut-brain signaling. So this is a diagram that was published by Mayer et al. And the A portion of this diagram shows this brain-gut microbial axis. So now we're adding the microbes into what we've talked about. So let's look at what's happening here. So we're seeing these microbes just at the bottom, and I'm sorry, I wish I was able to point, but I'm not able to point on this for some reason as I'm screen sharing, but you can see these bacteria right at the bottom of the A portion of the graph. And you can see how these bacteria in the gut interact with, from left to right, with the immune cells, with the epithelial cells of the gut wall, with the enteric neurons, right, of the enteric nervous system. They also act with these ICCs and ECCs, these enterochromaffin cells that are these endocrine cells in the gut that again help to send signals via the vagus nerve up to the brain to let the brain know what the state of the gut is. And this could mean what's the diet like? Have any toxins been ingested? Are there any infections going on? Is there any inflammation going on? Are there any antibiotics in the system? Are there probiotics, prebiotics? So it really gives the brain a very comprehensive picture of what's going on in the gut. And so that is done through, as I mentioned, through the vagus nerve and which goes up to the brain, but also through the HPA axis, right? Our hypothalamic pituitary adrenal axis. And now when we shift gears and we look at B, so B is showing us that if you look at, if you also go from bottom to top, abdominal pain and discomfort really may be due to this bacteria gut-brain signaling. Because what happens is, again, our brain receives this information that's being relayed from the microbiome and from the metabolites of the bacteria in the gut that's then sent into these various cells, and the information is sent up to the brain. And then based on this information, the brain makes decisions about gut motility, again, through the autonomic nervous system into the enteric nervous system. And then we're seeing enteric reflexes, motility, secretion, and that ultimately can affect our bowel habits, but it can also affect any symptoms that a person might experience. So let's dive a little bit deeper into the gut microbiota. And as I'm sure you know, this is such a fascinating area of research, and we're really just at the tip of the iceberg. But I'll share with you what we do know. So the large intestine can contain up to 500 different species of bacteria. And what's interesting is that the number of all microorganisms in our gut, so this includes bacteria, yeast, any potential parasites in our gut, outnumber our own cells by a ratio of 10 to 1. So essentially, you can look at our organism as this superhost that hosts all these microorganisms, and really we're just serving the purpose of of these microbes to replicate and do their job. But thankfully, there's also something in it for us. There are important roles that the gut bacteria play for our own health. So what are some of these roles? Well, number one is metabolic. So we know that they ferment foods, and as a result, they create short-chain fatty acids. They also act in vitamin synthesis of some of the vitamins, so vitamin K, and they also synthesize some of the B vitamins. They're also important mediators of inflammation and toxins. So they have anti-inflammatory properties, and they're also able to modulate our immune system and inflammatory cytokines depending on what metabolites they secrete and depending on which microbial peptides they secrete. So a lot of it's really the function of the microbiota in our gut that's important, not necessarily just what species are present and to what degree, which is also important, but what are they actually doing? What genes are they turning on and off, and what microbial peptides are they secreting? And they also protect intestinal cells from toxins as well. What about infections? Well, by secreting these antimicrobial peptides, our good bacteria can actually protect the intestine from colonization by other microbes. And then neurological and psychiatric. Well, we know that gut bacteria stimulate neurotransmitter production, and they're also associated with our stress response. And I'm actually going to share some of this data as well. So how is the gut microbiome associated with mental health? So as I mentioned, the metabolites of the gut microbiome influence these enteric endocrine cells to release peptide hormones, which then bind the receptors on the vagus nerve and enable the gut-brain communication. So information is sent upstream to the brain so that the brain can understand what's going on with the gut microbiome, what metabolites are being produced, and how is that affecting the ecosystem in the gut. Now, the gut microbiome composition, as I mentioned, influences what gut peptides are going to be produced and at what concentrations. Now, what influences the gut microbiome? Well, we know that diet influences this, right? So there are certain foods that we can eat as prebiotics that are going to serve as food for our gut bacteria. We also know that standard American diet is not necessarily a healthy choice for maintaining a healthy, diverse gut bacteria population. So fiber is really important. What else we're ingesting with our food, so whether it's antibiotics that we're ingesting, whether it's toxins, pesticides, this is all going to play a role. Just as a side note, for instance, glyphosate, which is a pesticide that's used on GMO corn and soy, and it's also used as a drying agent for oats, was patented as an antibiotic. So potentially ingesting glyphosate may also disturb the balance of the microbiome. So as I mentioned before, gut bacteria also produce antimicrobial peptides, thereby controlling the composition and really controlling the which populations are going to grow in the gut microbiome. And then medications, as I mentioned, the obvious one being antibiotics. And then, of course, supplements, as I mentioned, prebiotics and probiotics are going to influence our gut microbiota. So what about stress and the gut microbiota? So we know that dysbiosis is associated with anxiety, depression, autism, and IBS as well. What's really interesting is this review article, and by the way, I'm happy to share any of the references that I mentioned here, but this review was particularly interesting to me because they found that gut microbiota of individuals can change actually pretty quickly in response to stress. And in this particular review, they discussed several different studies, but one of them was on military personnel that was training in harsh conditions. So for instance, harsh weather conditions, extreme cold, and they found that there was a change in the gut microbiome as a result of that. And they also found that the gut microbiome also changes as a result of psychological stress in mouse models, but also in humans. And then on the flip side, they found another study found that when lactobacillus P8 probiotic was administered to stressed adults in a randomized controlled trial, the treatment group reported less anxiety and stress at 12 weeks after administration, or at 12 weeks of continuous administration, compared to placebo group. What's more fascinating is that in addition to this, pro-inflammatory cytokines such as TNF-alpha and interferon gamma were reduced in the group that was receiving lactobacillus P8. And it's also interesting that the lactobacillus probiotic helped enhance memory and cognitive traits such as social emotional cognition and verbal learning and memory as well. And this is likely, at least in part, due to reduced anxiety. So we definitely need more research to better understand the stress microbiome relationship, but also to better understand what specific strains are going to work in which individuals for which specific conditions, right? Because there are a lot of different variables at play here. But what we also know is that there are effective strategies that we can practice to cope with stress, such as mindfulness, meditation, breathing techniques, to just name a few. And so we can definitely use some of these modalities to help us cope with stress. We don't have enough information, though, if these modalities can then in turn help us change our microbiome. I think that would be really fascinating to study and understand better. Now, what about intestinal permeability in IBS? So let's talk about this. Intestinal permeability is thought to be important in the pathophysiology of IBS. And it's also been noted in subgroups of people with diarrhea-predominant irritable bowel syndrome. What's also interesting is that in patients with IBS who have eczema, asthma, or hay fever, studies have noted increased proximal small intestinal permeability compared to IBS patients without atopy, suggesting that increased intestinal permeability increases this autoimmune, this inflammatory response that can then lead to clinical manifestations of eczema, asthma, or hay fever. So what is intestinal permeability? Let's first talk about what's normal, right? What's normal intestinal permeability? So if we look at the portion of this diagram on the left, we see these beautiful epithelial cells here lining the gut lumen, this single layer, and then we see the blood vessel on the bottom, and then if you imagine at the top in the white is the gut lumen. So if we look at these 4 cells on the left, we see these normal tight junctions, right? And these selectively allow certain molecules to pass through. And so this is known as paracellular transport, right? The transport between cells in this gut epithelium. There's also transcellular transport, that is transport through the cells. And again, both very selective processes, but we see how tight these junctions are really and how perfectly aligned these cells really should be. Now on the flip side, on the right side of the diagram, we're seeing increased intestinal permeability. And what we notice here is that you can see here, number 1, is that the paracellular transport is now increased, and we've really allowed perhaps compounds that shouldn't be getting through, for instance, food particles, other antigenic compounds that we ingest, that are going into our bloodstream and that are being absorbed that really should not be absorbed. And then same as number 2, we're seeing more of the transcellular transport as well. So what can contribute to this increased intestinal permeability? Well, this study here has shown that glucose, salt, emulsifiers, organic solvents, gluten potentially, nanoparticles that are used by the food industry can potentially compromise the integrity of tight junctions in the intestine. An impairment in the tight junction in the intestine is a common denominator in a number of autoimmune diseases. And the mechanisms by which this is thought to occur is that if you imagine the tight junctions here being disturbed and we're getting this increased intestinal permeability, we're getting a lot of these antigenic compounds crossing this intestinal barrier. And as a result, our gut-associated lymphoid tissue is going to go ahead and respond to these potential antigens, and we're going to get an increase in the release of inflammatory cytokines and stimulate the immune response. So as I mentioned, once this barrier is destroyed, we get entry of foreign immunogenic antigens, and we get this activation of autoimmune cascade. And this is just another study or actually, sorry, it's part of that previous study that I mentioned, showing that there's a correlation between the net increase in the percentage of food additives with the increase of autoimmune conditions. So it is hypothesized that food additives and really just foreign substances that are not supposed to be in our food are in part contributing to this intestinal permeability and autoimmune disease. So what else can affect intestinal permeability? Well, you may have guessed that stress was one of them. So a study published in Nature found that chronic stress has been found to impair colon epithelium and barrier function in a rat model. So you might wonder, we talk about intestinal permeability, but how is it actually measured? So I'm just going to share with you a couple of different ways, and in the interest of time, I want to kind of make sure that we get to the rest of our discussion and some of the therapeutic modalities. But there are a number of different ways, and one of them is the lactulose to mannitol ratio, as well as looking at the antibody production against lipopolysaccharide, occludin, and zonulin as well. And zonulin is another way to measure this, but it's felt to be unreliable because there are other factors that can cause its fluctuation. So what is the standard treatment of IBS today? And really, we should all be familiar with this treatment, so I'm not going to spend too much time on this slide, but we know that we start with a low FODMAPs diet, and then we slowly start, after a period of time, we slowly start reintroducing the foods to see what the patient can tolerate, because ideally, we obviously don't want to keep them on low FODMAPs long term. And then for patients with IBSD, we are looking at interventions such as loperamide to help suppress or minimize this diarrhea. And then there's some other interventions that we can use as well in case of the failure of loperamide. And then for patients with constipation, we use psyllium. If there's no improvement, we consider a trial with polyethylene glycol. And then if that fails as well, there are a number of other alternatives that essentially help with fecal transit and gut motility. And then we can also consider antispasmodic agents as well for relief of abdominal pain in the short term. So what about complementary treatment modalities? So here, I wanted to focus on hypnotherapy, acupuncture, yoga, and mindfulness-based stress reduction. So this is the earliest study on hypnosis and IBS, but it's a really wonderful study because it really helps to highlight what are some of the possible benefits of hypnotherapy versus supportive talk therapy with placebo pills. So in this particular study, they randomized 30 patients, 15 to hypnotherapy arm, 15 to supportive talk, and you can see the hypnotherapy is the black circle and the talk therapy plus placebo is the white circle. And they evaluated 4 different domains or 4 different types of outcomes. And if you can see here on the graph on the left upper corner, we see that patients randomized to hypnotherapy did quite a bit better in terms of their overall well-being score. And then the bottom left, their pain was significantly more reduced compared to the controls. And then the top right, their abdominal distension score was significantly reduced compared to controls. And their bowel habit score was also reduced, which was a positive in this case as well. And there have also been several meta-analyses that I identified that are in support of hypnotherapy when it comes to relieving IBS symptoms. And unfortunately, just in the interest of time, I'm not going to get into this, but I'm happy to answer any questions regarding that. Now, what about acupuncture and IBS? So the thought behind this is that acupuncture can affect the visceral system by stimulating the somatic system, right? So again, there have been systematic reviews and meta-analyses published on this. The one problem with looking at acupuncture research, as you can imagine, is that there are a number of different protocols ranging in acupuncture. So some of these studies may have reported results after acupuncture for 3 weeks, up to 12 weeks. Some studies may have done 8 sessions total, others 20 sessions total. Some studies may have used Chinese herbal medicine, others may not have used Chinese herbal medicine at all, or may have used different formulations. So it's almost like comparing apples to oranges, unfortunately. So it's difficult to tell exactly, well, what is the effect of just acupuncture alone? But overall, if you look at these, the cumulative effects of these meta-analyses, the studies do seem to suggest that there is some benefit of acupuncture in IBS. So certainly something worthwhile trying, but we definitely need better, larger studies. And yoga and IBS. So practicing yoga is thought to balance our underactive parasympathetic nervous system, which we know is induced by stress. And we talked about the dysfunction in stress regulation in patients with IBS. And we know that yoga has been shown to be effective in reduction of stress as well as psychological disorders. So what about IBS? So again, another systematic review that was done in 2016, and this was done by a group in Germany. So it found that yoga could be a feasible and safe adjunct treatment in patients with IBS. However, they weren't able to make any clear recommendations because there were major flaws in the study methods, but also because of just huge heterogeneity in the way that the studies were designed and in the specific yoga protocols. So as you can imagine, again, some studies had very short follow-up, 3 to 4 weeks, others said 12 weeks of follow-up. Patients were assigned to do either different types of yoga practices. A lot of them are on hatha yoga, in case you're curious. And but then some patients might have been advised to do 10 minutes of yoga daily, others 2 hours of yoga every other day. So it's again, very difficult to compare and to really quantify what is the benefit of yoga. So what these study authors proceeded to do is they did their own study. So 2 years later, they came up with their own study, and they randomized 59 subjects with IBS to yoga versus low FODMAPs, actually. The yoga group did yoga twice a week, and the low FODMAPs group had 3 nutrition counseling sessions. And they got to do some food diaries and so on. And the endpoints at 12 and 24 weeks were done. The endpoints looking at the IBS symptom severity score. So this is one of the standard measures of IBS symptoms, where we look at pain severity, distension, bowel habits, interference in the quality of life. And by the way, the previous studies that I mentioned as well, most of them use very similar questionnaires that are IBS symptom severity score targeted, or they look at global symptoms, but a lot of these endpoints are the same, again, in case you were curious at what specific endpoints were the authors looking at. And as expected, both groups achieved significantly improved outcomes. So if you can look at here at this graph on the right, we see that the IBS symptom severity score goes from 0 meaning no symptoms, to 500, meaning maximal symptoms. So most patients, on average, I should say, patients started at about 250, at about the midpoint, but both the low FODMAPs group and the yoga group actually were able to reduce their symptoms at 12 and at 24 weeks. And they also found that the yoga group had hospital anxiety and depression questionnaire improvement. And this is a questionnaire that's used in Europe, but I'm not familiar from using it in clinical practice here, but it is something that had been validated in outpatient settings as well. And they also found that patients who did yoga did improve in the physical component of the short form 36 questionnaire as well. So what about mindfulness-based stress reduction, right? Because we know that stress is a big component of our IBS symptoms. So interestingly, there wasn't a whole lot of literature on this. So I'm just going to share one trial, but briefly, and I really wish we had more time to dive into this, but what is mindfulness? So mindfulness is really a way of cultivating awareness in the present moment and in a non-judgmental way. So this is a practice and a structured program actually that was developed by John Kabat-Zinn and has since been used in multiple academic settings for multiple different chronic conditions, and has been found to be quite effective in improving quality of life as well as improving a number of different symptoms, whether it be insomnia, depression, anxiety, and so on. So in this particular study, it's a small study, as you can see, they had 24 patients that they randomized to mindfulness-based stress reduction, emotion regulation, psychotherapy, or no psych intervention at all. And they found that MBSR improved the quality of life of patients with IBS, and it decreased their severity of symptoms as well. So what about herbs and supplements? So there have been a number of herbs and supplements that have been studied, and usually herbs are studied in combinations because And you may know this, but herbs are really intended to be taken in lower doses and in combinations because they have synergistic effects. And while on the one hand, this has been a common practice since the ancient times, in traditional Chinese medicine, Ayurveda, but it's really challenging to study something that has to be taken in combination, because then we can't isolate and say, okay, well, this particular herb has this action and this particular herb has that specific effect, I should say. So one of the combinations of herbs that's been extensively studied and has been used actually for about 50 years in Western Europe is called iberogast. And as you can see, this is a combination of herbs, and it is found to improve abdominal symptoms. It has a rapid onset of action. It has been considered safe and effective. However, I actually just recently came across 2 case reports of hepatotoxicity. So this is definitely something that needs to be obviously used with caution as a result. And in terms of probiotics, as I mentioned earlier, really we're just at the tip of the iceberg of understanding the microbiome and when and how to use probiotics. But we know that they have a role in protecting tight junctions, in stimulating the mucosal barrier production by goblet cells, which is protective, as well as in relieving abdominal symptoms of IBS. And they also help improve the IBS SSS score. And so in most of the studies used in this particular systematic review with meta-analysis that I cite here, most strains that were used were lacto and bifidobacterium strains. But again, as I mentioned, more studies are needed. And then there have been some studies showing berberine and grapeseed playing a role in protecting the intestinal tight junctions. Now, if there is an infection or SIBO, the goal is obviously to treat the infection or treat the small intestinal bacterial overgrowth. So how do we know if SIBO is a cause of IBS? So oftentimes patients will present with gas, bloating. This may worsen when they take probiotics and prebiotics, because again, this is just going to feed the bacteria that are already overgrowing. Fiber makes symptoms worse, constipation and or diarrhea symptoms. So there's a lot of overlap with IBS. Patients may report brain fog and just kind of this lack of mental clarity, slowing, change in their mood, low iron with no identifiable source or difficulty with absorption of certain nutrients. And then they may find that their symptoms improve when they take antibiotics, again, because the antibiotics kill the excess bacteria. So how do we test for SIBO? Well, we do the lactulose breath test. So in a fasting state, the patient drinks 10 grams of lactulose, and their methane and hydrogen gas production is measured through their breath at 20 to 30 minute intervals for 3 hours total. And so the rationale is that if SIBO is present, what's going to happen is the lactulose, which doesn't get absorbed, is going to be fermented by the excess bacteria. And as a result of that fermentation, we're going to get excess methane and or hydrogen gas. So it's interesting, methane-dominant SIBO is much more likely to be associated with constipation, and hydrogen-dominant SIBO much more likely to be associated with loose stools or diarrhea. And then in some cases, actually, hydrogen gas may not even be produced or may not even show up on the test because the methanogenic microbiota consume hydrogen in order to produce methane. So we have to pay attention to both gases. And then I'm actually just going to skip this slide in the interest of time. And I just briefly wanted to share this case study with you of a patient presenting with irritable bowel symptoms with diarrhea. So it's a 28-year-old female, hadn't felt well in the last couple of years since her diagnosis of Graves' disease. She's managed appropriately on methimazole, followed by endocrinologist who referred her for chronic GI symptoms and internal medicine care. She has always felt tired, even as a child. She said when she first came in, she was concerned that she had parasites because of some questionable food consumption. She felt bloated after her meals, as well as quite a bit of loose stools and stomach cramping that's relieved by bowel movements, as well as occasional diarrhea. She felt that she was sensitive to gluten, dairy, and legumes, so started herself on a very restrictive diet, actually on the this paleo-like autoimmune protocol. She was doing yoga a couple times a week, but still was reporting poor sleep, a lot of stress, and some anxiety symptoms. And normal physical exam was just borderline tachycardia. Her thyroid was enlarged, and she did have mild tenderness to palpation in her abdomen. And so so we did her diagnostic workup, and here I'm really just going to mainly focus on what the breath test showed. So as you can see, both the hydrogen and the methane, just in the lower left and lower right that are both circled in red, both of these gases were elevated, suggesting an excess of hydrogen-producing and methane-producing bacteria in her small intestine. I didn't test her for celiac, given that she was gluten-free already. Thyroid function tests were up to date, so I didn't suspect that her symptoms were in any way related to her thyroid function at the moment. And nothing else really too remarkable on her labs, other than the CRP that's 1.8, which I really consider to be high for a young, relatively healthy patient. So the stool study showed dysbiosis. It didn't find any ova or parasites, but you can see that there's no growth of lactobacillus species. She did have some healthy amount of bifidobacterium. And this 1+ yeast is considered to be normal. It's normal that we're colonized with yeast. We just get concerned when there's an overgrowth of yeast and how that may affect our gut as well as our symptoms. So here I just wanted to briefly mention this one study, this randomized control trial that was done on patients with SIBO out of Johns Hopkins that looked at 104 patients and randomized them to rifaximin therapy, as well, and the other group was randomized to herbal combinations, one of them being this combination of candibactins, and then the other combination of dysbiocide and epsicidal. And all therapies were a 4-week course. And these are all just different combinations of herbs. So for this particular patient, I started her on low FODMAPs diet, actually even before the SIBO diagnosis. She didn't have any significant improvement actually in low FODMAPs, unfortunately, at 6-week follow-up. We discussed rifaximin versus these antimicrobial herbs, and the patient selected to go on the candibactin. She did not want to do rifaximin. And by the way, in this particular case, because she had also methane-dominant SIBO, the treatment would be rifaximin plus neomycin is what's recommended. But what's interesting, she also started doing some breathing exercises. She started taking chamomile tea before sleep to help improve her sleep. She was taking magnesium glycinate to help with stress. She was reading a book on physical and mental wellness. So kind of mentally and emotionally preparing for wellness. And this, again, I'm happy to go over if you guys have any questions. So at clinical follow-up at 11 weeks, she reported her energy and mood were great. She was feeling less bloating, improved by greater than 50%, no loose stools, 1 to 2 bowel movements a day of normal consistency. What's interesting, she also noted that when she went on vacation, she was feeling even better compared to getting back home and working. So this is that relationship with how we handle stress. And in her case, she was no longer on a low FODMAPs diet, and she felt that she was tolerating a liberal diet well. However, her labs came back when she had this fantastic follow-up, and expecting that we have eradicated SIBO, what happened is that her hydrogen production reduced to normal levels, but we see this increased methane production. So what's interesting is that the patient's symptoms improved, but physiologically, we're still seeing that there's clearly this overgrowth of methanogenic bacteria, unless, of course, this is a false positive. If, let's say, she didn't fast, or she has very slow transit time, which is not the case with her. But in her particular case, she did fast and she did the test properly. So I don't think this is a false positive. So this is really just one example of the power of the mind-body interventions in SIBO, and really how the mind-body interventions that she was doing with her breathing exercises, with her bedtime routine, with improving her sleep, with changing her outlook, and maybe in her particular case, not stressing herself so much about the food, how this actually helped improve her symptoms. So as the next course of treatment, really this is where rifaximin and neomycin would come into play for methane-dominant SIBO, but in her and a retrial of low FODMAPs diet. But this particular patient wanted to do a trial with another combination of antimicrobial herbs. So this is the way that we proceeded, and stay tuned for further results. So just to recap on the objectives. So we talked about the gut microbiome, brain connection, bidirectional, right? We understand what the interactions are going back and forth. etiology of IBS. So we talked about all the different factors that can be implicated in triggering or causing IBS and how this gut-brain connection plays a role. And then we talked about treatment, conventional, complementary, and targeted treatment, really depending on the patient's symptoms and the root causes. And again, I really want to encourage you to empower your patients by discussing the gut-brain connection, by discussing some of these integrative modalities that have sufficient evidence that patients can practice on their own, whether it's mindfulness-based stress reduction, whether it's breathing techniques, whether it's attending to their sleep hygiene and being mindful of their stressors and maybe changing some lifestyle patterns. This can really greatly affect their symptoms. And then it's really important to collaborate with a team of physicians, dietitian, acupuncturist, yoga instructor, MBSR instructor, clinical hypnosis, psychologist to deliver, and of course, Epicured, to deliver effective treatment and make sure that we give the patient the best chance of adherence. And so this is really just another slide showing that improved understanding of the condition leads to improved compliance. Patients feel confident in the approach. And then we can really implement that personalized health plan that's based on evidence. And so this is just a quote that I like: when I is replaced with we, even illness becomes wellness. Thank you so much for your time. I know I went over a little bit, and I welcome any questions.
Well, it was really phenomenal content, so I'm sure no one is complaining. You've held the crowd's attention wrapped, including ours. Thank you so much, Dr. Bojana. We have a question. How is intestinal permeability diagnosed? Are there reliable tests for that?
Yes, so this is one slide that I went over. So actually, let me share the screen again, because this is gonna help a little bit, or I can just go over it without sharing it. But so one of the ways in which—
Oh no, go ahead. Take back the screen. Go for it. We'd love to see it.
Oh, perfect. Let me go back. Oh, you know what? I seem to— oh, here we go. All right.
Great,
so
we can
my
see your
cursor
screen.
is kind of playing games with me here because it kind of comes and goes. So maybe I'll just answer it without it. It looks like I'm not able to share screen for some reason. So one of the tests that I mentioned is this, and yeah, I'll share with you what I do in my clinical practice, and then I'll share with you the 3 tests that I briefly went over. So one of the tests is the this lactulose mannitol test. So so the goal is to have the patient drink the lactulose, and we measure after 6 hours. We measure the ratio between lactulose and mannitol in urine. And if we found that, so lactulose is a much larger compound than mannitol. So if we find that the ratio in urine is greater than 0.02 of lactulose to mannitol, it means that lactulose has permeated the intestinal wall and permeated that barrier and has obviously made its way into the urine. And so that's one way in which we can tell that the gut wall integrity has been compromised. We expect mannitol to go through because it's very small, but we don't expect a whole lot of lactulose to go through. And so if the ratio is less than 0.02, then we know that, okay, lactulose is not getting through the gut wall, it's not getting into the urine, so the likelihood is that there's no increased intestinal permeability. The other tests that I briefly mentioned are the IgG, IgA, and IgM antibodies against lipopolysaccharide, occludin, and zonulin. So these antibodies are secreted when we activate our immune response, right? And I talked about the gut. I wish I could go back to the slides, but that's okay. But when I talked about the gut, the intestinal wall barrier, we talked about the transcellular and the paracellular transport. And when you compromise that transport, when it's no longer selective, you're getting all sorts of antigenic compounds getting into the bloodstream and really passing or sending signals to the gut-associated lymphoid tissue. This lymphoid tissue, the immune system of the gut, gets activated as a result of these antigens, these foreign substances, these toxins that we don't expect there, and they start secreting these antibodies. So that's the rationale between looking at these IgG, IgA, and IgMs, because they really shouldn't be against lipopolysaccharides, which really should not be present in the absence of compromise to the intestinal permeability. Now, unfortunately, this test is actually not available in New York. Now, zonulin is another marker, which unfortunately is also not available in New York, but what it does is it transports antigens across the epithelial cells of the gut wall, so from the lumen and into the bloodstream. And it does so because of the complex interaction between the intestinal mucosa, the microbiome, and then gluten or other potential foods that the patient may be sensitive to. And so zonulin increases when that transport of these antigenic, again, foods or toxins is increased. So we expect zonulin increase when there's more intestinal permeability. However, this is not considered to be a reliable measurement because there are other factors causing zonulin fluctuations. And this test is also unfortunately not available in New York. But I'll share with you what I generally do clinically, just because we're so limited in New York in terms of what we can order as far as these innovative lab tests. Another thing that I know some clinicians do, and again, yet another test that we can't order in New York, but I'll tell you anyway, in case there are some practitioners that are not in the state, is IgG testing. So there's there's been a lot of controversy over the years over the utility of IgG food sensitivity testing, because it's not really, it has nothing to do with food allergy testing per se, right? We're not looking at IgEs. But IgGs, what they look at is, and again, the rationale is similar, are we developing an immune response to what we're ingesting? And it doesn't necessarily mean that if we develop IgGs against eggs, does that mean that we can never ever have eggs in our lives? No, it doesn't. It just means that if somebody has a panel of IgGs that is pan positive, meaning that there are IgGs that are positive to multiple different foods, it is likely that this individual has compromised intestinal permeability or increased intestinal permeability, because clearly some antigens are getting through that shouldn't, and your immune system is just so activated that it's producing all these IgGs. So it just means that, okay, we need to figure out a way to repair the gut so that eventually you could go back to eating all these foods. So some clinicians use this as a kind of surrogate marker of that. In my practice, again, because we're so limited in what we can order here, for me, I use it as a clinical diagnosis. I may not necessarily know for certain if this is the case, but if I know that somebody has had a history of multiple antibiotic use over time, if I know that they've had a recent history of infections, if I know that they're currently having gut symptoms, or even in the absence of gut symptoms, in fact, if they're having autoimmune disease, I know that one of the potential activators of that is likely through the gut, because this is where we're getting most of the information about our environment, is through what we're ingesting. And this is really the inside, the intestinal lumen is really kind of like our interface with the outside environment. Even though it's inside our bodies, it's really our way to detect what's outside of us. And so I look at those risk factors to determine, okay, well, what's the likelihood that this person has increased intestinal permeability? So I hope this helps.
Absolutely. Thank you for the very thorough answer. We have 5 more questions that have come in. So for those of you who can stick around, which it looks like almost everyone is, which is phenomenal. Again, indication of how much your expertise is really appreciated, Dr. Bojana. But please join us. Otherwise, this is recorded so you can hear. Next question is, what strains of probiotics do you recommend for IBS treatment in particular? And do you recommend symbiotics, so paired with a prebiotic?
Mm-hmm. So that's a really good question. So this really depends on so many factors. So let's just start with with one portion of the answer. Do I recommend symbiotics? It really depends. So if I've diagnosed SIBO, or if I'm suspecting SIBO, some patients that are treated with probiotics and or prebiotics while they have small intestinal bacterial overgrowth may experience an exacerbation or worsening of their symptoms as a result of ingesting pre or probiotics. And the reason is that what we're doing with by giving patients prebiotics is we are potentially feeding this already overgrown population of bacteria in the small intestine, and by feeding them, we're allowing them to ferment these amazing prebiotics. However, the end products are then just more methane and more hydrogen gas. So this may result in more bloating and more abdominal distension, discomfort, pain, gas. And so this is something that we definitely want to be cautious about. In terms of which specific, so I do have a few different combinations that I like to use. I know that this is CME, so I'm not supposed to mention any specific companies. So I can definitely look up the specific ingredients of some of the probiotics that I use, and maybe I can share that. Would that be the most kind of productive way to do this, or? Because it's a combination of a number of different strains. I don't just use one. So I want to be mindful of being, brand agnostic given the CME, but at the same time, I want to give you the information that you asked for. So I'll take your guys' lead on this.
Yep, absolutely. So if they post a follow-up here, we can certainly, connect you.
Mm-hmm.
Otherwise, any kind of course,
but generally, I'll just
share via email.
Sure,
Yeah.
I can just speak in general terms. So generally it would be strains of lactobacillus and bifidobacterium. And sometimes, especially if we're talking about antibiotic associated, or if they've had antibiotics in the past, I may add in Asboulardi. And the other emerging trend, which there's not as much data on this, but there are some companies that are developing spores, and these are, these claim to be more resistant as they're passing through our GI tract, so more resistant to stomach acids and so on. So they're less likely to be destroyed, right? Because there's always the question of, well, how much of the probiotic that I'm taking is actually making it all the way down to my gut? And there's some questions of, well, how much of this is really seeding the gut and so on. So we know that we're getting an effect of the probiotics, but the question is, what's the exact mechanism? And I think this is something that really needs to be further elucidated. But anyways, there goes the argument for potentially considering some of these, using these spores. And again, I'm happy to share, the resources that I use and some of the combinations that I use.
That'd be really wonderful, and we'll make sure that that's sent out to the rest of the group. Mm-hmm. Yeah, and I have the email address for this particular person, so we'll be happy to connect you to directly. Perfect. As well. On similar lines, with regards to supplements and herbs, given they're not regulated, how do you help patients with making the right choice?
That's a great question. And there's no one straightforward answer, but one of the things, and I did include this on one of the slides, is there are a few different ways in which you can look at websites and databases of unbiased information to really determine, is this something that's going to be safe and effective? What are the studies? So one of the databases that I use is the Natural Medicines database, and this provides both efficacy data, studies on various herbs that you may be interested in using, but it also provides herb-drug interactions that are really important to know about. So this is a wonderful evidence-based site that I recommend, and there is a membership fee that's required for people to be able to look that up. And then the other one, the other database that I like to use is Consumer Lab. And Consumer Lab is, again, another unbiased source of information where they test various supplements for, number one, the claims that they're making of what specific ingredients they contain, but also they look at impurities and potential toxins. So that's another useful resource. The other thing that is helpful to me is knowing what are the brands that over time have gained their reputation and how do they do their quality control. And so again, this is something that just over time, in working with my colleagues that also prescribe or recommend supplements, rather than sending my patients to Amazon and having them pick a random supplement brand that I know nothing about, there are actually some curated databases, and one of them is called FullScript, where you can register as a provider, and then you may be able to, even if you want to just, recommend a simple, if a patient needs vitamin D repletion or iron or B12 or prenatal vitamin, you may be able to go on there and they have a curated selection of these, and you know that you're actually getting the product from the specific manufacturer and brand that they're claiming you're getting it from. And again, you know that they curate brands that are more likely to adhere to higher quality control standards. But I agree. I think that we overall need more regulation. I think the other piece too is that that a portion of the patient population that comes to me, because I do integrative medicine as well, I do have some patients that only want supplements. And so it's more really me trying to manage and make sure they're not taking too many rather than prescribing more. So it's really just kind of managing, okay, well, let's do, these specific ones that have been shown. And I share with them, I'll share studies with them, I'll share the level of evidence, and I'll say, okay, well, here's conventionally what we would do. And then here's the integrative medicine approach or the functional medicine approach, and here's the level of evidence. And sometimes, as we know, even in conventional medicine, we don't have a whole lot of data to go off of. And sometimes we have much more data to go off of. So I'll share with them, what are the pros and cons? What are the risks of going with one approach versus the other? And as I mentioned, some of my patients may want the more, oh, did I lose you guys? Hello?
No, I think we can hear you.
Okay. I thought I lost you for a second because something happened on my screen. So it really depends, obviously, partly on the patient preferences, but more importantly than that, really making sure that before the patient formulates what their preferences are, to really fully understand the risks, the benefits, and the level of evidence that's there, because there are a lot of there's a lot of misinformation out there, unfortunately. And so it's my role as their physician to really be able to pull out, okay, well, what's evidence-based? How much evidence do we have? What could potentially be harmful, and which direction really we should take.
Wonderful. Thank you so much. So we've got a couple of food questions.
Mm-hmm.
One is about anti-inflammatory foods. They've gotten a lot of attention. And Don is wondering if you had particular comments on this and how you recommend or leverage them in your practice. And along similar lines, what are your thoughts on organics? And are you recommending only organic fruits and vegetables for your patients?
Mm-hmm. That's a great question. So in terms of organic versus inorganic, one of the resources that I love to use is EWG, Environmental Working Group. And full disclosure, I'm their board member, but there's no financial ties to them. But even before I came there, that's why I became a board member, because I believe in their mission. I believe in the quality of their research, and in what they're aiming to do to really protect the consumers, because unfortunately, the level of protection that we're getting, not only in terms of our food, but also our skincare products, our household products, is very, very low. When you compare, the United States to the European Union, for example, or Canada, in terms of environmental toxins that we're being exposed to. And one category of these toxins are pesticides. So one of the great resources that I like to use that you may be familiar with is EWG's annual list of Dirty Dozen and Clean 15. And these refer to fruits and vegetables. The Dirty Dozen are the ones that are the most heavily sprayed with pesticides and that are considered to be safest when eaten organic. And the Clean 15 are the ones that are the least sprayed with pesticides, or the ones that at least have a thick skin that you may be able to peel off and then eat the actual product that doesn't have a high concentration of pesticides, that are considered to be relatively safe. So although I don't necessarily think that everybody has the ability, and especially if we're eating out of season, if we're eating, and by the way, we should ideally be eating foods in season, but if we are eating out of season, and if we are, or if we're not able to either find or afford all organic, I especially then refer people to these two lists, at least to know, okay, you know what, if you can't get your strawberries organic, just maybe skip them until you can, because you may be exposing yourself to pesticides. And then the other piece that I mentioned, I spoke about glyphosate specifically. So I do think this is an issue, actually, and this is one of the areas that that I speak about as well, actually. Because it has been classified as a probable carcinogen by the International Agency on Cancer Research. And so to know that something that's classified as a probable carcinogen is in many children's breakfast cereals, is in our oats, is in our corn and soy, most of which is GMO anyway, that's really alarming to me. So for that reason, I do talk to patients about organic and just about being mindful of what they're getting, what to try to stay away from. And of course, you know, as we know, we're exposed to so many things. We have to make so many decisions every day, even just adhering to a particular diet that's nutritious and healthy for us. It's hard enough. I also tell people not to overstress if they can't follow every single recommendation, because it's really about minimizing your risk in a way that's realistic for you and your circumstances. We can't be perfect in every way, but we can certainly do some things to protect ourselves. And then in terms of the second question about anti-inflammatory diets, so yeah, I don't know if you had any specific questions about any specific foods, but in general, I don't believe that there's, you know, one size fits all and there's a one diet for everyone. I think that this is something that, and you know, we're finding out more and more about the different benefits of different diets. And, you know, we have the proponents of keto and you have the proponents of low carb and plant-based. And, but what I do think is that based on all the evidence available and just based on what intuitively we should know over the course of our evolution, we should all be eating mostly plants. Now, whether somebody tweaks this a little bit and changes it because of their own needs, because of their own symptoms, because of their preferences, that's another thing. I actually just read this study that was published in JAMA, I believe. I just received it a few days ago in my inbox, and it was a 2020 study that looked at low carb versus low fat diets. And of course, the final conclusion was that, well, neither one really wins. It's really about the quality and about the micronutrients. It's not just about the macronutrients. But, you know, we've known this all along, but we're sort of, unfortunately, kind of putting all these categories for really no great reason other than possibly for, you know, marketing or whatnot. So I do believe that, and in counseling my patients, I do discuss incorporating more plants in our diets. I mean, we know that, I believe the last time I looked at the statistics, it was around 10 or 11% of adult Americans were eating adequate amounts of fruits and vegetables on a daily basis, right? So we know that we all need to boost our fruits and veggies. And then we want to look at well-sourced, high-quality ingredients as much as possible. Be mindful of portion sizes. Be mindful of anything that comes in a package and anything that has a long list of ingredients and so on. I mean, I could talk about this forever, but I think this is probably what you were asking and kind of the what you were looking for.
Wonderful. Thank you so much. Okay, we've got the last couple of questions here. Thank you, everyone, for such wonderful questions. Is there a treatment, or what is the treatment for intestinal permeability?
Mm-hmm. That's a great question. So it really goes along the lines of what we had discussed earlier. So in terms of intestinal permeability, right, if we think about what are some of the causes, right? So we talked about the standard American diet. We talked about antibiotics being given over and over again and affecting our gut microbiome. We talked about dysbiosis playing an important role in intestinal permeability. We talked about I just mentioned not enough plants in our diet, not enough fiber in our diet. So first we want to look at, and we talk about stress as a cause of intestinal permeability. So first we really want to look at the foundations, and this is really kind of how I approach every patient that I see, right? We first want to address what is the least invasive way, what is the most natural way that my patient can start to implement some of the changes to help themselves, to help their body heal, to help in repairing, whether it's the dysbiotic gut microbiome, whether it's intestinal permeability, whether it's IBS symptoms. So when we look at this foundation, we ask, well, what are you currently eating? How do we optimize your diet? So as I just mentioned, plant-centric diet, lots of fiber, making sure that they're not eating processed foods, and then all of the other things that I mentioned, glucose, salt, emulsifiers, food additives, all of those different categories that were studied in one of the articles that I was talking about. We want to be mindful of our ingestion of these because they can all affect our gut permeability. So we'll use nutrition as the foundation. Then we talk about stress, right? We know that stress affects our gut microbiome. So then how do we manage stress? Well, similarly to the modalities that I presented for managing IBS, mindfulness-based stress reduction, yoga, acupuncture, hypnotherapy, all of them can actually be used to manage stress. There are a number of breathing techniques that can be used as well. Obviously, sleep and sleep hygiene are extremely important in managing stress. So you can counsel your patients on all of those modalities as a foundation. This is really going to be important because no matter what medication or supplement or herb you give, if you don't have this foundation, your intervention is going to be either short lasting or not going to have any effect at all. And this foundation is the most difficult to establish, right? Because how many people tell you that, well, I'm too busy to do this, or I can't sit still, I can't meditate, or I've tried, it doesn't work for me, or it's really hard in my, on-the-go lifestyle, I don't have time to eat healthy. So we want to consider, all of these factors and really help counsel and support our patients to implement as many of these as possible. Now, in some cases, there may be a role for probiotics. In some cases, there may be a role for prebiotics as well, again, to boost our good bacteria populations. Some practitioners use L-glutamine, which can be supportive in terms of the gut intestinal barrier. I don't think there's enough evidence for this. So again, I'm just sharing something with you that from clinical practice in functional medicine, this is something that can be used. And so this is really what I would base the interventions on. And then if we think about other toxins, such as whether it's antibiotics, whether there could be other medications, thinking about, well, how do I help my patient optimize their state so that they're not having to go on multiple courses of antibiotics and so on. So this really, I would use this as the first approach in repairing that.
Wonderful, thank you. And finally, our last question of the evening, do you use chelation therapy, and is there evidence to show that that is effective in treating gut disorders?
So chelation therapy is generally used when we know that there is an increase in, I'm assuming you're talking about chelation therapy in the setting of heavy metal toxicity. And there are different ways in which one can chelate or help with the toxicity of heavy metals, right? So the most kind of aggressive methods would be the IV, EDTA, and so on. I do not do this in my practice, but this is something that if I suspect heavy metal toxicity, let's say, it's just a very simple example, if I'm thinking about mercury, right? If somebody's eating a lot of seafood, if they've had a certain shift in their symptoms that are not explained by anything else, I may check a mercury level. But again, this highly depends on there are ways in which, if their levels are just slightly elevated, there are ways in which we can help them, which we can help people detox in a very gentle way, whether it's using chlorella and cilantro, whether it's supporting their antioxidant activity with NAC, glutathione, and I've seen people's levels go down very nicely, again, assuming that their levels are just very slightly above the normal range. But if I do see somebody with which I haven't, with a serious heavy metal toxicity, I would definitely refer them out. That's not something that's within the scope of my practice.
Wonderful. Thank you so much. Very engaging presentation, obviously, and wonderful questions. Your expertise is so valuable to our community. We're so grateful for your time tonight, Dr. Bojana. Can't thank you enough. Everyone, please check out her site. Follow her on social. She'll be continuing to share expertise with this community. And again, thank you. Thank you. Have a wonderful evening, everyone.
It was a pleasure. Thank you. Have a great evening.
Bye. And the recording will be in your inboxes soon. I know I had a lot of requests for that. So you can come back time and again and glean all of the wonderful gems from the presentation if you weren't able to capture them quickly enough, given the incredible amount of wonderful content you provided to us. So thank you again, and good night.
Thank you. Good night.
Bye.